Thank you for this great introduction, Dimitrios. I'll try to do my best to defend my presentation, which you made. Okay, the title I had is Stereotaxy, Robotics and Image Fusion in Interventional Oncology, Toys or Tools. And this is an interesting title because without willing to talk about all the topics which will be discussed later, I will try to summarize my position. And at the end, as you will see, I have no conflict of interest. I will be a little bit provocative or polemic, try to stimulate the discussion. Briefly, I will talk about pros and cons of the three modalities and some notes regarding the actual diffusion in the world. A stereotaxy. It is absolutely critical for me to talk about stereotaxy in front of a chairman like Reto, who is the real boss of this modality in the world. The modality is not absolutely new. The first paper was published 14 years ago. So it is not a new modality. The requirements, as you know, are many: general anesthesia, using CT or MRI or CBCT or PET-CT or fusion imaging for localizing a lesion. It is a frameless stereotactic 3D navigation. You can use robots for the alignment or no robots, coaxial needles, and of course you need a machine which can activate simultaneously 3 or more probes. The indications of stereotaxy are many, remaining in the field of liver. What Reto and his group underlined for many years are lesions in difficult locations, large lesions, multiple lesions, and recurrences, and metastasis, intrahepatic cholangiocellular carcinomas, and HCC. All the 3 of them can be treated with this modality. What are the positive points of stereotaxy? Many. Low radiation exposure, wide angle, real-time procedure, no need for repeat contrast injections, low cost, excellent outcomes, as it was demonstrated 5 years ago by this brilliant paper published by the group of Innsbruck in transplanted livers after bridging therapy by SRFA, in which the pathological response was achieved in 97.3 lesions. Extraordinary result. So these are the many papers, some of the many papers produced by the group of Innsbruck, more than 45 papers. Any other center, there are few additional papers published by the groups in Bern, for example, in Switzerland and in Stockholm, but not so many. What are the cons? Very few. Need for general anesthesia, the relatively long duration of the procedure, at least of some of them. And another possible limitation is that there is a huge experience in only one center in the world. Why that? We will discuss about that. Then is there a need for great technical experience? Absolutely no. In this paper published again by the group of Reto, 3 experienced radiologists and 1 novice radiologist were compared, and there were no statistical differences in the different fields between the 4 people. So it is a technique which can be done by many different operators, also without a long experience in ablations. What about robotics? Is it new? Not at all. Robotics started in the 80s in the surgical field for stereotactic brain biopsy, for the urological surgery. And in the abdominal surgery and in the urological surgery, there is a continuously increased utilization, and many publications are going on almost every day in this field. In interventional oncology, robotics started some years later. In the first publication is in 2006, moving from CT fluoroscopy to the CT robot with navigation tool. There are many models available, for sure. I just mentioned here 6 of them, 6 of the most common: the MACTIS, the EPION, the CAS1, Maxio, ISIS, and Micromade. And also we have not to forget that there is also augmented reality or mixed reality, which can be used in the group of robotics. Are all these models identical? No, they have different characteristics, different from in terms of size, of method of guidance, system of guidance, degrees of freedom, active or passive guidance, single or multiplanar needle planning. Complexity of use is different from one to the other. General anesthesia can be mandatory or not needed, depending from the model which you use. Also, the real-time monitoring and adjusting for patient respiration and or needle deviation can be different. So there are some differences in this group of machines. But are there many pros? Definitely, a lot of pros. User-friendly interfaces, ergonomic workstations, reduced radiation exposure to the patient, and even minimal or no radiation at all to operators, depending from the model selected. The lesion segmentation and the automatic virtualization of the trajectories can be achieved very easily. Reduced or no needle repositioning and readjustments, improved precision and control of the procedures, short learning curve, very important, particularly for novice trainees, increased accuracy of needle placement, do not preclude the utilization of other guiding modalities simultaneously with robots. The adverse event rate is extremely low without significant differences between robot and manual guided procedures. Procedures become more standardized, more reproducible, and reliable, definitely. Less institution specific, less operator specific, and also there's some particular notes regarding the commodity for the operator, less prolonged in standing, less awkward postures for the operators, so less physical strain, so also some physical advantages for the operators. Are there cons? Definitely yes, but very few. Little longer procedural time compared to ultrasound or CT guidance. Technical challenges when in cases of depth perception, in case of pressure feedback, and so on. Complications due to technical challenges, they have been mentioned, but in reality, they have not been significantly reported in the literature. The cost effectiveness can be a negative point, especially when you select some relatively more expensive machines. Training costs and need for skilled staff are also they reported, but not so frequently. Image fusion. Image fusion is new? Not at all. Even image fusion is an old modality. The first clinical applications were in 23 years ago, 23, in Italy and in America. In the beginning as a fusion of real-time ultrasound with pre-acquired CT for localizing difficult lesions, undetectable for ultrasound, or inconspicuously visible with ultrasound. And just to mention one paper published by our group 9 years ago, 95.6% in a group of 295 tumors were correctly targeted and ablated using fusion. Clearly an enormous advantage. So when in centers when the US guidance is used, image fusion is absolutely fundamental for planning the ablation trajectory, to target lesions undetectable with ultrasound alone, and for the immediate verification of the result using contrast-enhanced sonography. In centers where CT or CBCT or robots are used, it is also fundamental for the pre-treatment planning and for the immediate verification of the outcome with CT or with combi CT. Again, fusion is absolutely fundamental for the final verification of the outcome achieved using the ablation confirmation software. And I totally agree with the paper published by the group of Retobale years ago, that ablation confirmation software should be mandatory after every ablative procedure, possibly, if feasible, immediately at the end of the procedure, with the enormous advantages. But is it used, routinely used in particular fields? Extremely used, for example, for the prostate diagnosis and treatments by urologists. But in centers of interventional oncology, is it significantly used? Absolutely no. Not more than 10, 15, sometimes 20% of the centers use image fusion. So this, I'm just close to the end with just my provocative portion of my lecture. So toys or tools? Definitely, technologically and technically, they are tools, no doubt about them. But despite their great advantages, Are they widely used in clinical practice? Stereotaxy is used only in few centers in the world. Robotics, again, is used in not many centers in the world, even though they are slowly increasing in number. Image fusion is utilized in a very limited number of centers, both for guiding ablations and for the verification with the software. And why? Because most interventional radiologists still today prefer to use conventional modalities of guidance, the old ultrasound, the old CT guidance, because they feel they are faster, easier, less time consuming, and paradoxically, even more cost effective. Also, some centers where robotics and fusion are available tend to use them only for few particular cases. In that situation, they become again toys, no more tools. And we should, in any case, try to overcome this trend. The problem is the carelessness, which is the real problem, in my opinion, of many interventional oncologists still today. Some years ago, Henry Ford said and wrote that the true progress is only made when the benefits of a new technology become accessible to all. They are accessible, but not many centers, not many interventional oncologists use them. So I have accepted with great pleasure this publication, recent publication by the group of Bruno Disio, promoting and stimulating this protocol of stereotactic liver ablation assisted with CT hepatic arteriography and ablation confirmation software, all of them in the same procedures. And I replied, publishing my comment on cardiovascular interventional radiology, saying this is the way to go, in my opinion. Thank you very much for your attention.
Thank you so much, Professor Solbiati. That was an excellent presentation. Before we proceed to the next speaker, I would like to ask you specifically for margins verification, how important they are, and should we try to implement margins verification in our everyday clinical ablation practice?
Thank you, Dimitrios, for this question. It is an extremely important question. As I said, margin verification should be done for every procedure, even the easiest procedures. We must, let's say, compete with our surgeons. And as you know, surgeons send the specimens to the pathologist, and the pathologist gives a very precise sub-millimetric evaluation of the margins. We cannot do that, but with the software now, we can come very close to that result. In my opinion, no more interventional treatment should be performed without a final verification with software. Of course, if it is done immediately, it is the best, because in case of incomplete or inadequate margins, you can immediately enlarge the margins. If not possible, at least the day after the procedure, in order to assess the result precisely. In my opinion, we should push as much as possible that for the next years, even including this possibility in the reimbursement of procedures. In my ideal future, in many countries, procedures should not be reimbursed if there is no documentation of the results achieved. It is a very strong statement, but we should be strong at this time. We cannot be still back to 10 or 15 or 20 years ago. This is my opinion.
Just being provocative here, I guess that your answer actually implies that we should move all ablation performance to the computed tomography suite.
Absolutely, I agree. I agree. Even using sonography, but in the CT room, definitely. This is not the way to go today.
Okay, and just staying on margins verification, I'm not going to ask you about rigid versus non-rigid, but my question is, do we need general anesthesia specifically for margins verification, leaving aside all ablation performance?
General anesthesia should be the ideal modality for a precise verification. It's not needed, in my opinion, in 100% of cases, but it is, let's say, suggested. The problem, as you know, in many countries, like Italy, for example, is the lack of anesthesiologists. It is not easy to find anesthesiologists available for the interventional room, but we should also push for that. We should not, in the next years, perform interventional treatments without an anesthesiologist close to us to assist us.
Thank you so much.